I will be talking on circumferential MIS and deformity correction. So let's understand why, especially we as a Indian, or at this part of the world, we should understand adult degenerative scoliosis. If you look at this newspaper cutting, it says we need fewer schools, more job and hospital beds. The government priority is changing. What does that even mean? Look at the population dynamics of India, how it is changing. So this is where the population dynamics was in 1980s. That means that 95% of the people in India are less than 30 years old. This is where we are today, and this is what will happen in 2050. What is happening? We are getting older as a country. That means if you are in your 30s or 40s, you're likely to see more cases of degenerative scoliosis than you will see cases of disc disease, and that is why you should understand this problem. These are not easy things to do. They come with a lot of challenges. You have a problem with patient selection. Remember, they are old patients. They have comorbidities. They have bone quality which is not that great. Even if you fuse them, they do lead to pseudoarthrosis. Even if you did a good job, they will come back to you over a period of time because of PJK. It is not that you are failing, but it's just the aging process which is likely to catch up with you. If the patient outlives your surgery, there is a good chance he will come back to you. And even if you do a good approach like Sham showed, there are problems with those approaches. There are problems with anterior approaches. There are problems with lateral approaches. They does come with their own problems. And this is one of the famous classification which tells you how to go about these cases when you are doing adult degenerative scoliosis. Now they have grouped these cases into levels from level 1, 2, 3, 4. So as the level of problem increases, so is the type of surgery you do. For example, a level 1 issue where you have only a radiculopathy might need just a decompression on a discectomy, but in a full-blown scoliosis, you will have to do osteotomies, you need to correct deformities, and you need to tackle everything. But look at this paper which analyzes do benefit overcomes risk related to adult degenerative scoliosis. It is a detailed analysis of the issues with treating this case. And look what happens if you increase the level of the surgery. Now, a posterior fusion might have lesser problem, but look at deformity correction, that the complication rates that has been reported could be as high as 40%, and that is the problem of treating this case. And that is where I believe the minimally invasive approach comes into picture. So now we have all talked about how to do it. Let's see what are the limitations and what are the benefits of circumferential MIS in treating these cases. So there is enough evidence now. I think most of the guys who are sitting, and that's why you are sitting here, you are convinced by the very fact that circumferential MIS does work, and there is a lot of evidence, and not only that, it says that this is a safer approach. Even if you look at the outcomes of this approach, it does convey the outcomes are good, or even at least at the best comparable to any other outcome of open surgery. So if you have to treat this 56-year female with a laminectomy done 5 years back, and you know there are many ways to do it, but this is just a simple, and this is how the patient looks like. You have a kyphosis, you have a lumbar canal stenosis, and this we did a single level OLIF and MIS fusion, and this is what we could achieve. And remember, these are revision surgeries. You see the posteriorly everything has been taken out. Of course, all of you are a very good surgeon and you can do it again posterior. But why to go there if you have a better approach to do this? And if this is what was done, and not only that you got the alignment correct, but look at the decompression which you achieved. And this was his previous scar, and this is all you have given. And remember, this is not just about scar. It is what you did. Instead of going for a revision surgery, you went anterior, you took a completely virgin approach, and you got your job done. And Why OLIF? Now this is a case where you have a TILIF and OLIF because the anatomical corridor on L4-5 was not good enough to do a OLIF. So we went for OLIF and TILIF and they equally look good. But see, the cage of OLIF is just 8 mm compared to a cage of TILIF which is 10 mm. Although they are like the TILIF cage is bigger in size and everything, but they are both doing a good job, and I believe the OLIF does a better job in these cases because it is not only about the height of the cage, my friends. Now it is more about the length where it sits. The OLIF cage or the anti-ATP cages that sits on the cortical rim, and that gives them power to do what they do to correct these deformities. Now look at this case, this is a 61 female. We have done a Lamy and everything earlier, and this is how she presents with us. And there's a Dejan Scoli, there's a 30-degree corpse angle, their PALL mismatch is 38.2. Everything is, there's a lot of foramen stenosis. If you look at the MRI, sometimes it is very difficult to make out from where the pathologies have come. Some of the facets are really, really bad. You have stenosis at one level, a facetal problem at another level. And that is where you go ahead and you simply go into here and do these cases. And look at the beauty how the spine simply restores back. Forget the lumbar spine. Look how the thoracic spine has behaved once you have corrected the lumbar pathology. And this is the final result of this case, and this is what you got. And this is a post-op MRI. And look how everything has sort of restored back, each and every level. Instead of, really finding out what went wrong where, you can really get it right. And this is a long-term follow-up. Look at those facet joints. It's not only about getting those big cages and getting the height. It is about the remodeling of the whole spine. Once you restore the anatomy, the spine simply remodels itself. And this is exactly the same cut pre-op and post-op and tells you how the spine behaves. So, just a few more examples, and this just to show you the workflow. This is how the workflows goes like when you're doing these cases. You start from L5S1, then you go to L4. That is normally how we go, and you start correcting one level by other, and you try to restore the whole alignment, and that is how it is. This, and if you are doing a multi-level TLIF compared to a multi-level OLIF, most of the time you're much faster, you're much better than doing these levels. I think if you're doing a one level OLIF and one level TLIF in terms of times and logistics, it might not matter. But when you're doing these multi-level, I think any given day, and those who do OLIFs or do ATP approaches, they'll tell you we are much better, much faster. The whole workflow is much more easy when you're doing these cases. So this is another case, we did a TLIF 60 for this male 4 years back, and this is something like Sharma's case, what he was presenting earlier. And again, a circumferential MIS was done. First you threw a bit of laterals from the lateral position, and then you turn the patient, and you can do all MIS, and that is the beauty of all these patients. And this was the first paper which sort of started talking about circumferential MIS, and this is from the Neil Anand. And this is what he tells. Now, he normally talks about the deformities in the range of 30 to 75 degrees, which can be easily be tackled by this. And people are sort of getting bigger cases. They are really pushing the limits. But I think this is the practical range which I think you can really achieve when you are talking about the circumferential MIS. And I think if you're a beginner or novelist, I think that is where you should stay when you're trying to attempt these cases. And this is me with him, and this is 4 years back when we were together. So this is my protocol of treating deformities in adult population. I always believe if you do small, you fail small. If you do big, you fail big. So do small, and that is where it is. Either do a small endoscopic discectomy, or for me even a circumferential MIS is a smaller surgery compared to a full-blown deformity correction by posterior. And that is why I believe even when I'm doing maybe a 5-level O-lift plus posterior MIS fixation, I'm doing a smaller surgery. And the chances of me failing is small. So thank you so much.